conference will now be recorded.
Alrighty, good evening, everyone. Welcome to AnCan's Active Surveillance Group. As Eric mentioned, it's being recorded this evening. You're more than welcome to turn off your camera or perhaps change your screen name if you're so inclined. And if any of that kind of bothers you, you can just watch the recorded message meeting next week. Again, Active Surveillance Group. All of us are on active surveillance. If you have received treatment or are undergoing treatment, you are certainly welcome to stay, but we don't discuss treatment, and we can well advise you to go to one of our other groups, which are people that are going through or have had treatment. First, we'd like to thank the sponsors who make this possible. That'd be Bayer, Novartis, Johnson & Johnson, their division Janssen, Myriad, Telix, Blue Earth Diagnostics, and Foundation Medicine. All right. Okay. Well, we don't have any new people this evening. So the first person I marked down for wanting some time is sitting in the car, Brian. That's what we'll call him from now on, because it seems that every time we see this guy, he's sitting in the car. Now, he always says he's waiting for another meeting, but it really makes you wonder what the guy's doing sitting in his car. But Brian, take it away.
Well, I'm at the church right now, and I got another meeting at 6:30, which is in an hour and a half from right now. So I really do have another meeting.
I'm just pulling your leg, Brian.
I know. I'm glad
that you're here. Trust me.
I just wanted to get that on tape. That's all.
All right, good.
I'm glad to be here. Thank you. I really appreciate this. This is like I even got a new guy to the group last night. His name is Greg. He's met 4 or whatever it is, and he was like the second guy to talk. So I felt really good about that. I got another guy too that I'm going to plug into that meeting. Okay, so basically, I try to do what you guys tell me to do. Not tell me what to do, but I try to take suggestions from what I hear.
Okay.
And basically get a PSA. I went and got the PSA. I already told you that went up just a hair after my aquablation. And then you guys told me to see the urologist. So I was in the other group Monday, the intermediate group, and kind of told them all this. But I like this group, so I'm going to tell you just a little bit about that. So I went and saw the urologist, a brand new one at the VA. And I said, hey, I told him, I said, hey, look, I had an MRI in August of 2025. I diagnosed with BPH. I had my aquablation October, and they pulled the sample out and they found 3+4. The sample they pulled out was 70% tumor. And I had to bring all my notes. Somebody suggested make sure I have all my notes there. I think maybe it was Eric or somebody. Bring all your notes, because he didn't have anything there. Even though I already sent everything to them, I had all my stuff. Basically, he said, okay, so they found a little cancer. Okay, so what we need to do next, and you guys told me just to listen. So I listened to what he said. It was really difficult to have a conversation with him, which was, kind of bothered me. But he said, what we got to do next is we have to do a biopsy, a 12 core. I said, yeah, I agree. I said, can we do that MRI guided? He said, no, we can't do that. I said, why not? He said, because you already had an MRI in August. He said, but what we're going to do is we're going to wait. You have to wait 6 months after an aquablation, 6 months before you do another PSA. So we're going to do the biopsy in April or May. Now, my other urologist that did the surgery said, check your PSA after 3 months, which I did, which it went to 5.2. And it was 4.7 or whatever. But this doctor says, no, we got to wait longer, because after you do the aquablation, we got to wait 6 months. He's been a urologist for a long, long time. And I said, are you a oncologist urologist? He said, that's the clinic you're in right now. You're in the clinic. You're in the oncology urology clinic. That's what he said. So I said, well, how about a perineal biopsy? He said, no, you don't need that. He says, your prostate is too small, 28 cc, to do that. And I said, well, he said, we just don't do them. I said, okay, really? So he said, there's nothing to target. That's why we can't do another MRI right now, because we already did your MRI six months ago. There's no nothing to target. Your PIRAD's 1-2. The 2, he goes, it's a nothing. It's nothing. So he just wants to do the transition. No, he's over what's it called? The outside of the prostate biopsy, that where they take 12 cores. And I know I'm kind of scattered here, but that's kind of where we're at. So
you mean he wants to do a transrectal? He's telling you he can't do a transperineal.
Yes, correct. And I know you guys should just go in other places. The UW is right there, and so is the Fred Hutch. But I get all my care through the VA, and I can't just go anywhere else. But I am seeing my primary care in 2 weeks, so I'm going to bring this up with him. But he even mentioned years ago the same thing. So I don't know. I'm kind of there at the VA. So that's where I'm at. I can't really, unless I can convince him.
One thing about the VA, now we have an excellent VA group that you can join. I suggest you go talk to the captain.
I've listened to it.
Yeah, he now I don't know if you can. Now, community care is just something real quick with the VA where you go outside the VA facility if they feel that they can't do what you want to be done. Where's that feedback coming from?
Hello, you need to mute. Thank you.
Yes, the community care, like the aquablation, the Seattle VA didn't do that procedure, so I did community care at another hospital, and the VA took care of it. But now that I'm done with that procedure, they want me back to the VA.
I understand that, but perhaps I don't know if you can try to opt for a transperineal via community care, because that's what you're insisting that they do. But they're most likely going to fight you, I would think. But you can ask. I'm
going to try.
Ask.
I'm going to try.
When you see your primary care guy, say, look, I really don't want to take the chance of getting sepsis. I play up the sepsis word a little bit, and they're going to tell you that, oh, the chances are less than 1% or whatever. And then you can just tell them, well, I don't want to be that 1%.
No, he said 1 in 300. 1 in 300.
I don't give a shit. You don't want to be.
No, I know that's even worse. No, that's even worse.
You don't want to be the 1 in 300.
No, I don't want to be the one. Okay, and I also got Medicare. So but I've never used it.
Ray, you got something for
Brian? Brian, remind me, where was the lesion on the MRI?
It was in the transition zone.
Okay, you're better off with transperineal anyway. It'll access it. You can access it better.
I suggested that to him, and he just I don't know. He just
he doesn't do it though, right? Does he do transperineal?
No.
Okay, he doesn't do it. So he's going to tell you that, oh, it doesn't matter or whatever. But you can access first, or in the transition zone, it's accessed better through a transperineal, and you don't have the chance of sepsis. The other thing is, and I hate to sound like a broken record, people have heard me, but the transrectal, they usually give you a fluoroquinolone antibiotic as a prophylactic. And I had terrible tendonitis. They're supposed to give you a black box warning. They generally don't, which means that if they can use something else, they should use something else. But that's the other thing that
I asked him about that specific question because I take very good notes. And here's what he said. He said, that's true. You do get tendonitis, but that's only if you take it 7 to 10 days in a row. I said, oh.
Well, but BS. I got it almost immediately. I took it for 3 days. It took me 8 months and in fact, I'm still dealing with it with patella tendonitis now. So that you can develop it almost immediately. It just depends on the person and your reaction to it.
Brian, apparently there was an alternate to the what's the antibiotic we're talking about? The chloroquinolone.
Fluoroquinolone type, which is like levofloxacin or Cipro or something.
Yeah, Cipro, because I just had a biopsy 2 days ago, and they gave me a one-time shot. They didn't have me take anything orally, and they said it was a massive dose. And I said, well, what is the antibiotic you're using? Because I was worried about what you're talking about. He said, no, we don't use that anymore because of antibiotic resistance. And we use a more powerful antibiotic, and it wasn't the one with the black label. So.
Okay.
Do you know what it was, Mitch?
No, I think they mentioned the name, Gary, but it didn't sound familiar to me, so I didn't,
Genomycin?
might have been. Yeah,
Might-
it was
It
a
might be in
massive
your order.
check,
Or-
and if I
The
find it, I'll
order
get back.
for your biopsy might show it.
Yeah, but it wasn't Cipro. I know I've had Cipro in the past, and I had that concern, but apparently some places are not using that anymore.
So when they do the biopsy, those transrectals are always done with an ultrasound, correct? Because that's what he said. They stick the probe up there, the ultrasound, so it's guided with the ultra. Okay. And then,
Yeah, both versions have the ultrasound to look at the prostate and guide the needle.
say that again, Eric.
Both procedures use an
Oh,
ultrasound
okay.
to guide the needle to the prostate.
He seems to think I don't need an MRI because I just had one, and he with the PIRADS 2, he just said that's nothing. You don't need one. So
I would consider, when you do decide to get a biopsy, I would think getting a fresh MRI and then trying to find a doctor within the VA that may do transperineal.
I'm working on that. That's my goal. And then one last thing. And I'll try to do community care because they said they just don't do them. They don't do them, period. He actually told me there's no difference. There's no difference, but I already know what the difference is. So there's no difference. So
There's a big difference between
know.
the rectum and the skin between your testicles and your rectum. I can't believe a guy would say there's no difference. I mean, he's an idiot. I just can't believe somebody would say that. I mean, just the basic of medical knowledge would know that there's a difference between the rectum and going through the perineum. But
I was blown away. But I don't need anything done in so that means the transrectal won't hit the transition zone. Is that correct?
It will, but you can access it as well.
Okay.
With they can,
Okay.
but it's easier. I mean, let me just double check. I'm 99% sure. So it's in the transition zone. Let me just double check on this. But
Well, it definitely won't reach the front part of
Yeah.
your prostate, because that's on the other side from your rectum. So
Israel, have you got a quick question while Ray's checking that out?
Yeah, no, just a quick comment for Brian. Brian, I would just highly recommend that you look for another urologist. I mean, this one seems like he has a lot of red flags, and I had a kind of quote fire mine when I first started, because when I first started, I didn't know anything about the whole prostate issues and whatever. And once I started learning, I was like, whoa, wait a minute, this doesn't sound right. And I would just, it doesn't hurt to get, another urologist.
Yeah, I'm gonna be talking to my primary care about that. I think he was good and great. I think he was good, but I need some different information. That's all.
Yeah, the more informed you are, the better you can be your own advocate.
I'm getting to.
Go ahead.
Oh, I'm getting pretty informed listening to you guys, like 4 hours every day. So
that's a good thing.
That is a good thing. Thank you. That's all the questions I had. Thank you for letting me talk.
Albert, you've got something for Brian?
I do. I was thinking, if you've got Medicare and you could go to Hutch with Medicare, you have a supplement. It's a traditional Medicare with a supplement.
I don't have a supplement.
Or is it Advantage?
It's just the basic, AB.
Okay, you got A and B. Well, the thing is with B, there's the amount you would pay if it was a self-pay, but if there's the Medicare contracted amount, so you might call Hutch and say, what's the Medicare contracted amount? And you would still owe 20% of that.
Okay.
But I don't know, if it's a $7,000 procedure and 20% of it is affordable to you, maybe that would be a solution. It's just an idea. But I would call his business department and see what the price would be, the Medicare price, and see what your actual out-of-pocket might be.
Okay, that's what I was thinking about, and that's for the guided MRI biopsy, basically.
Yeah.
For the whole thing.
You could get a transperineal.
Transperineal, of course.
Hector, you
MRI
got
is
something
being
for Brian?
guided, yeah. Sorry.
Hector?
Yeah, I have just two quick comments. One is that I have a Medicare Advantage plan with Florida Blue, and I have done the works, several biopsies, SMA, PET scans, MRIs, and never got charged. Covers everything. So having a good plan is important. Number two, I've been to several support groups, and the consensus I receive is the transrectal should be deemed as malpractice. I mean, the dominant paradigm is transperineal, so many urologists are just dinosaurs, let me put it this way, looking backwards. They are not updated, so just get a second and maybe a third opinion.
Yeah,
Okay,
that's what we always preach here, Hector, for sure.
Thank you. Thank you.
Okay, before
Anything
we
else
move
for us?
forward, real quick, Hector, you joined us a little late. Do you need some time tonight? Did you want to talk or ask any
Yeah,
questions?
you're gonna spend some time. I can share my case. It's gonna be interesting to hear.
Okay, have you been here before, Hector?
A long time ago, several months, and I spoke with Jim Schreider at the time.
Jim Straight?
Yeah, Jim Schreider, and he very generously gave me some personal time for a one-on-one. And to make a long story short, maybe I can expand on that later. He told me, Hector, don't get treated unless that thing is killing you. And it's not killing me, so I didn't get treated. I'm still on
Okay.
active surgery.
All right. We should have some time. And Ignacio, you joined a little late. Do you need any time?
My
to see you.
apologies for joining a little late.
No problem.
I'm still a working SAP, and I get home late from work. I'm on the West Coast. I do not need time. Thank you.
Okay. Well, we just, no problem. We're glad that you're here. But if we had extra, if we have some spare time, if you had something to share, I want to make sure if I know that. Okay.
I appreciate
Brian,
it. Thank you.
anything else we can do for you? Anybody else got anything for Brian? Okay. All righty.
Good. Thank you.
Hey, Brian, real quick, your doctor that did the procedure, he says how long before your next biopsy? 6 months?
The one that did the procedure, the aquablation.
Yeah.
He told me 3 months, and that's why I went and did a PSA. But when that was at a separate hospital through community care, 3 months. But the VA doctor told me 6 months. No, you got to wait 6 months. So that's
For the biopsy or for the PSA?
basically the PSA, and they're going to do the biopsy at the same time, which, yeah.
Okay. Interesting.
That most probably the 6 months most I sounds like a good number after aquablation. Michael, you have a thought on that? By any chance, the length of time before they,
That's
I would
that's where I am. That's their recommendation is about 6 months. Yes.
Yeah, I thought 6 months sounds like a good number versus 3 because that aquablation is a pretty big deal. Alan, what do you got?
I just would say I didn't have the aquablation. I just had the biopsy. They did my PSA accidentally at 3 months and it was elevated. I talked to my doctor. He said it's too soon. Even after the biopsy, he said, I don't want to see the number till 6 months. By the time we did it at 6 months, I was back to normal.
Wow.
6 months sounds reasonable, Brian. So
good stuff. Thank you. Thank you.
All right. BJ, what do you got for us?
Hi, everyone. I was freaking out about my MRI this morning. It was going to be my third MRI since April 2024 because of the noise. So I ordered an item from Amazon, which I put on the link on the chat in case anybody has an interest. And then I also walked into a shooter's lounge and try to get one of those shooter's moldable silicon, and they had never had anybody coming in asking for that was going to have an MRI. So I was first customer on that. And anyway, so I used the one from Amazon, and then I put the shooter thing on top of it because it just kind of like expands. And that basically took care of at least 50% of the noise that had freaked me out the previous time. And the whole thing lasted about 25 minutes. I was really impressed by the quality of the people there helping at the UCLA. And my next stop would be hopefully next month with Scott Eckner, if he doesn't cancel out on me, to kind of take over my case.
BJ, did you get a multi-parametric, with contrast, or a biparametric?
Yes, I got it with contrast and without contrast recommendations from our friend Ray. And so I guess I tried to cover the whole gamut.
Okay. Yeah, I'm scheduled in early March, and I've requested a biparametric. The shorter time I can spend in the tube, the better. And from what I've learned with the group or some of the studies, that biparametric will work. But I was just curious if you got a multi-parametric.
Mm-hmm.
When will you get the results?
It's funny, they gave me a disc like 5 minutes afterwards, which I'm about to send for a second opinion, I guess, to our friends at NIH, thanks to Eric. So that was my next move.
Okay, excellent. So your radiologist hasn't read it yet, your group?
No.
Okay.
Usually takes a few days.
Yeah, it's funny, when I go to the Mayo, I go in the evening, I go in the afternoon for blood work. They get it back in 15 minutes or 20 minutes. Send your phone a message what they found.
Oh, wow.
And I get the MRI in the early evening between 7 and 8. And I meet with the doctor at 11, and he's got it. He's got the results. He's got the report.
Wow.
Because they know I travel to do this, so I have to stay overnight. So, I don't know if that's standard operating procedure, but that's what they've done for me.
Report might be on the CDs. Did you look?
Usually the CD is just the scan files.
Okay, all right.
A radiologist hasn't typed up a report yet.
No, not yet.
I have never asked for the CD, so I'm going to ask for the CD this time because
they just cranked it right there. So
yeah, I'm hoping nothing's changed. And but if I do get it, I'll get that address from you to send it up to the NIH or whatever. BJ, is there anything? Anybody else have anything for BJ, or BJ got anything for us? Be sure you get back to us after you get the you get the written report as far as what they see and PIRADS and all that stuff.
I shall. Thank you.
Excellent. Okay. Olu, good evening, sir.
Good evening.
Yeah. You want to kind of refresh us with what's going on?
Yeah. So I was first diagnosed in 2020. And the way it went was my PSA went up to 4.7. I was 56 at the time. And so my PCP recommended I see a urologist, which I did. I'm in Frederick, Maryland. And the urologist I saw suggested that we do an MRI, which we did in March of 2020. And I'm sorry, that's the MRI or a biopsy? I'm sorry, biopsy in March of 2020. And the result came back as all negative, except I think about 5 or 6 atypical cells. And he recommended that we do a repeat biopsy in 6 months, because he said in most cases, those atypical cells will turn into cancer. So I said, okay. So in November, we did another biopsy. And this was the
traditional biopsy is not transperineal. I didn't know anything about this, all of this at the time. So we did it, and the result came back as one of the 12 samples has less than 5%, 3+3, grade 1. And so I asked him what was my next move, and again, not knowing anything at all about all of this at the time, he said if it was him, he wouldn't do anything. But I didn't understand what he meant by that. He didn't explain to me that there was a treatment called active surveillance. He just said he wouldn't do anything, but he gave me treatment options, taking the prostate out, radiation, all of that. But he said if it was him, he wouldn't do anything, but he didn't explain anything to me. And so I came home and I told my wife, and so I just got on the internet and started researching, and that was where I found the health board. And I joined the health board and joined the prostate cancer and started asking questions, and was getting some good advice about. Actually, there's a gentleman on there who's been on AC for I don't know 20 years or more. But anyway, that was how I was able to get some more information about active surveillance. One of the things I was recommended to do was to send my slides to Johns Hopkins, which I did. And I came back as the same. It was that one, less than 5% on that one sample. And and then they also recommended that if I was going to do active surveillance, I should do it at some, Center for Excellence. So I kind of figured, well, Johns Hopkins. So I looked them up and made the arrangement, made the appointment to go up there and join the program. Now, when I joined, my doctor, Dr. Pavlovich, said he would need to do another biopsy to confirm that it's just that one, there's nothing else. And so we did another biopsy in, I think that was in,
Must have been 2021, maybe?
October of 2021.
Okay.
About a year
Yeah.
later.
And what'd they find out?
And that came all negative, no cancer. So I was doing PSA every 6 months and MRIs in between, like every 2 years or so. And I just did an MRI in November. And the result of that MRI was similar to the first one. By the way, I'm also taking finasteride because I also have BPH. I've had BPH even before the cancer. And my understanding is when you're on finasteride, you have to kind of, if you've been on it for a while, you have to double your PSA results. So my PSA has been trending down up until the one I just did last week. And prior to that, it was 2.1. And then it just jumped in 6 months to 3.4 last week.
Same lab?
I'm sure you're going to get a couple of questions. The first one's going to be, is it was the same lab? And did you do anything before this particular PSA test that you should know? That's not a crazy jump. That's nothing I don't think to get crazy about. Okay, 2.1 to 3.4 is not. It's not doubled. It's not. It's nothing. And plus, you've got to wait another 6 months to get another test to see what. It might bounce right back to 2.1 in 6 months. But did you go to the same lab?
Yeah, I use LabCorp all the time. Well, I found that on, when I was doing my research, that it's recommended you do your lab at the same place all the time. Mm-hmm. So since this has happened, I've been doing my labs at LabCorp. It's the same location. Now, last year, I usually meet with Dr. Pavlovich once a year, and I'll do my PSA every 6 months. And when we met last year, he recommended that we do another biopsy since it's been about 3 years.
Wow.
So I actually have a biopsy that is scheduled for April 24th. And our next meeting is March. So we're going to meet in March, and I already have a biopsy that is scheduled for March, for March 24th. So when I saw the result, I sent him a message, and it said we will just meet. That is aware of it, and that we just meet at the time we're supposed to meet.
Hey, Ulu, it's Eric. Were any of your biopsies MRI guided first?
Yeah, it was guided by ultrasound, I guess.
Did they do an MRI and then use the MRI to guide the needles in the prostate? Call it fusion, MRI fusion guided.
I'm not sure if they use it to guide, because when it's going on, I'm usually just out of it. Because
No, I mean you would have an MRI like a week or two beforehand, and then have a biopsy.
No.
Jeff,
I
that's
had an
your
MRI last month.
Jeff, that's your doctor, right? Pavlovich?
Yeah, it is. Hey, Alu, Jeff, I have Dr. Pavlov. Somebody, we're getting a lot of feedback.
Yeah, I'm going to switch my headset. To my headset. Give me a second here.
Yeah, we hear ourselves in the room.
Not now.
Okay. Okay.
Check.
Hear me?
That's better.
Oh yeah.
Yay, no echo. Go ahead, Jeff.
All right. Is this
okay? All right, that's good. Can you hear me now? Can you hear me?
Yes.
Switch.
Go, Jeff.
I don't know if you can hear me or not.
Yeah.
If you can hear me, Alu, put a thumb up.
Lulu, give us a thumbs up if you can hear us, please.
Okay, I can hear you now. I can hear you now. If you can hear me, I can hear you.
There we go. Okay, that's what I was wondering. Everybody else, they don't give a shit what I got to say. Anyway, no, I'm just kidding. No, I'm simply going to say that I also go to Hopkins. I also have Dr. Pavlovich.
Okay.
But and Eric had asked you if they utilize an MRI, and and you said Pavlovich already gave you at least one biopsy. I'm surprised that he would not recommend, like Eric was asking, an MRI to see if there's anything to target, like a lesion seen on an MRI, as well as giving you the 12-core, typically systematic biopsy, that kind of surprise.
I've had 2 MRIs with him. I just had one in November.
And he did do he's already given you one biopsy, correct, Pavlovich?
Correct.
I suspect he would have used the MRI. Maybe you just don't know that to utilize. Well, okay. I don't know. You haven't said anything about what your MRI results were.
Yeah, the last one. The last one I did in November, it was the same thing as the first one, which is overall pyrites is 2/5. Overall follow-up score precise, stable MRI appearance, no new focal tissue lesions, 3 out of 5.
What?
Overall assessment. Hulu, any lesions? How many lesions were noted? 1, 2.
1 second here.
Hopefully less, 1 or less.
Narrative MRI prostate
with contrast 3D. All right, here we go. Demonstrating small focus of atypical glands. Okay, the comparison to the one from 2023.
Yeah, was there a change from 2023?
No.
So he doesn't have anything to target
no.
anyway.
Your most recent one was when again? MRI.
Hemorrhage, no area of high T1 signal suggesting hemorrhage. Prostate volume.
November 25, Jeff.
November 20. Okay. And then he's going to do March 24th. You've got a biopsy scheduled then, huh?
Correct.
Well,
I don't see any. I'm sorry. I don't see anything about lesion.
Well, that's a good thing.
Good.
That's a great thing.
That's a good thing. And then maybe that's why he wouldn't utilize potentially an MRI, anything to guide it. A biopsy MRI guided because there's no lesion to target.
On top
so far, and no one's really found much of anything. I'm surprised anybody's asking you to do anything else other than stay on active surveillance, and especially with such a minimal increase, like Gary said in your recent PSA. I'm surprised. I know he said it's been 3 years, but with nothing on an MRI and no change on a PSA, I mean, not much of a change. This sounds dramatic. I'm surprised, whether it's been 3 years or not, that they would want to do another MRI.
Barry, can I jump in for a second?
Sure, go ahead.
Olu, you're like the human pincushion. You're going on your 4th biopsy. I got to tell you, there's a big problem with the way you're approaching this. And the two most important things we use in active surveillance to establish our trend line is the MRI, which you're doing, but it doesn't really show anything yet, or anything suspicious for cancer yet, and the PSA. You cannot use your PSA reliably if you're on finasteride. I mean, I know you read there's formulas you can use to estimate it, but that's not good enough for us. So finasteride is a game changer for you and active surveillance, because, one of our most important screening tools is basically not really going to be very accurate in you. Now, finasteride is a great drug for shrinking your prostate and helping your BPH, but there's a lot of controversy about whether it's a good thing for patients who have cancer. There are at least some suggestions, and I don't know, Rick may be more up on current literature, but there are at least some suggestions from the older literature that people who took finasteride had more high-grade cancers than was expected. And high-grade cancers are the ones we definitely don't want. Whereas it sounds like when you started off, you had a very, very small amount of low-grade cancer, and that would be a better place for you. And there's other ways to treat your BPH that may not interfere as much with what you're trying to do with active surveillance. So, I think this needs like a pretty serious discussion with the urologist and maybe some other urologists who will give you a different perspective.
Now, I just saw somewhere where it mentioned lesion on the top. Impression, stable evaluation, no MR evident interval suspicious prostate lesion identified. That's the only place where.
So your MRI your MRI is not really finding anything, which is good, and your PSA is not really accurate. So, all these guys telling you they want to keep doing biopsies, I mean, they might as well just turn the lights out and start shooting in the dark. I mean, I don't know what you've already had one, since your diagnosis, you've already had one where they did the systematic biopsies and it came back negative. So I don't really know what they're hoping to accomplish here, besides running up the tab a little bit.
Now, this MRI I'm having, I'm not sure, because the way it's done with him is they pick the date date for you. They pick a date for me, but there is no time. So I don't know whether at this meeting it's going to say, you know what, maybe there's no, based on the MRI, maybe we shouldn't, I don't know yet, but we'll see. Because
Yeah,
I'm meeting with him in March, and the biopsy is scheduled for April, but no time for the day.
Man,
I'll get him to try to tell you, you know, why he feels this biopsy is necessary, and also bring up the finasteride and see if
Okay.
he thinks that there might be a drug out there that can help you as much, and see what
Okay.
his opinion is. I know we've got a couple of
Okay.
people that want to interject. Jeff, something?
There were a couple people ahead of me.
Hector, yeah.
I thought there was.
Well, I'll get to everybody.
Well, just real quick, Olu, one thing, since I have Pavlovich, the reason he may want to do another biopsy is because I think he tries to stay somewhat within the NCCN guidelines for people that are on active surveillance, which they can say can be from 1 to 5 years, you know, biopsies depending on individual situations. But like I kind of just was going at earlier, and I think Dr. Dan there was alluding to this, is you've had 3 biopsies and I haven't really found anything except for that tiny bit, or maybe it was your second biopsy, and it's almost without an MRI, anything nasty coming up on your MRI. I don't know why they want to keep poking you, to be honest with you. That's what it sounds like to me. So that's all I've got.
Certainly.
Okay.
Hector, you got something?
Appreciate it.
Yeah, I got something to say, and it's just based on my personal experience and maybe pretty controversial, so bear with me. But my findings are that the PSA is a very lousy indicator, and the NCCN guidelines are kind of in desperately need of updating. And the reason why is because I've been pretty methodical with my PSA readings, and I plot them in Excel spreadsheet and did the math. So it came with some doubling time, about 4 to 4.5 years, which is slow because typically it's a nonlinear relation. It's based on an exponent base 2. And if you get a doubling time about 9 months or so, well, you have to worry. But that wasn't my case. So I was pretty reluctant to treatment. So my numbers went from 2.5 to 4 to 10. When it was 10, half of the specialists were telling me, hey, you gotta get treated. 15, came all the way to 20. And then, according to NCC guidelines, I had to be treated and I had to be placed on Lupron or whatever. And then my general practitioner told me, listen, I'm gonna give you finasteride, so they give you a break. And all of a sudden, my levels came down to 7. And support groups will say, well, yeah, we gotta multiply that by 2. Well, you get 7 times 2, that goes 14. It's not 20. And then came down to 6. And then came down to 5. And ever since is not moving up. It's been flat for about 12 months. So I go with a specialist and tell me, okay, you want to be treated. What do you make of this? And the last one that did a biopsy, after we got the genomics, the decipher, it came low risk, which substantiated that the PSA was not a good indicator. And he told me, listen, Hector, I cannot see a man like you eye to eye and with a Gleason score of 7 and tell him that he's got to be treated. I saw some other urologists and they were like, well, my friend, if you have been in active surveillance for 10 years and you're still alive, just keep doing what you're doing. So even though last time I joined this group, I was told to go to the intermediate, which I go also, that's my case. So I did some additional research because I was concerned about why my PSA was just getting flat for a while. And what I found, and I mean, that's going to be subject to controversy because I get my COVID vaccination.
Hey, Hector,
Yeah.
can we shift back to Olu's case before we hear yours and finish up with him? Is that all right? Hector? Okay. I want to finish up with Olu's case before we move on to
Yeah, I
Hector.
thought he had a comment for Olu. I didn't ask him to, he's next, then Mitch.
Right.
Yeah, Hector, come back when we're done with Olu and we'll hear what you have to say for sure.
Yeah.
That's good.
So Olu, I guess where we left off was your doctor will have a consult in March, and you can ask him about whether the biopsy in April is really necessary, huh?
Mm-hmm. Correct.
And then Rick, you had your hand up?
Yeah, I did. Really in response to Dr. Dan about to what extent do the 5-alpha reductase drugs, which are finasteride and dutasteride or Avodart and Proscar, to what extent are they related to more advanced disease? So I just was doing a search because from time to time I run across articles on finasteride, and I usually write them up and put them in your reminders, and we usually carry them in the AS reminder. And so I was just looking recently what we've written up, and I came across a couple of interesting articles, one of which I've posted there, and that's the most relevant article. And that was a study done, hold on a minute, and I'll tell you when it was done. Recently, it was published recently. But it found absolutely no correlation between the use of finasteride and dutasteride and prostate cancer mortality or even overall mortality. So you can click on that link and you can read it, but it would suggest, and this was done on 20,000 prostate cancer patients in Ontario between 2003 and 2017. Bottom line, no association with either overall mortality or prostate-specific mortality. It did find a bunch of guys with very long hair. No, just kidding. Now, for those of you who don't know, the drugs that make your hair grow are these same drugs, but in a much lesser concentration. So
the takeaway is it's pretty much for BPH?
The takeaway is it's safe. Now, the reason why what Dan says is absolutely true. There were years when I got diagnosed, the word around the place was, well, we see more higher grade cancers in people who use dutasteride or finasteride. The explanation that sort of came out after 2 or 3 years, I think around 2011 or 2012, was that these drugs shrink the prostate. And when you have a smaller prostate, it's easier to hit the target. And so they were finding more targets in the smaller prostate because there was less real estate. And they were coming up with more positives and they were coming up with more higher grade cancers. That was the explanation. Now, there was one other article, just to show you how crazy some of this research is. There was one other article that I also saw last year that suggested that there was greater suicide ideation. That means suicidal thoughts in men who took finasteride and dutasteride. The numbers are really small. There was they did this study and there were 352 people out of, I don't know, 353 million men years that had suicide ideation. I mean, it's crazy stuff, but it got published. They say maybe it's because you have a lower libido when you've got that. That was the suggestion. I didn't put that. If anybody wants that reference, I'll put it in, or you can. It's probably in one of the old reminders. Okay.
Thank you.
My 2 cents on finasteride and dutasteride.
Any other questions for Ulu? Or do you have questions for us, Ulu?
No, this has really been very helpful. So I really know what kind of questions and some of the discussions I'm going to have with my urologist in March.
Okay. Sorry,
Eric,
Dan.
I have a question for Ulu.
Go for it.
I think I may know why his urologist wants to do a biopsy. From what I've read, it's very unusual for the PSA to go up on finasteride. So the fact he's having his test done at the same lab, and I presume you didn't do any long bike rides or have sex within a few days of your test. So I guess that could be enough. The rising PSA on finasteride could be enough to make his urologist nervous. And since his MRI, yeah.
However, this biopsy was scheduled a year ago when my PSA was actually trending down.
Well, then I can't explain it. You need to have him explain it to you.
Yeah. So because this result is just from last week, this 3.4 is just from last week.
Yeah. And I would like to comment on what Rick said, which I think is really important. I mean, the reason most of us are in this active surveillance group and why we call it anxious surveillance is because we like very much to avoid any treatment that's going to deprive us of our masculine skills, shall we say. Olu, you know that finasteride, as Rick mentioned, does lower your testosterone. It is likely to reduce your muscle mass, potentially weaken your bones, and produce decreased libido and erectile dysfunction. So there are other ways to treat your BPH that would possibly affect your lifestyle less than finasteride. So I think that would be another interesting or important discussion to have with your physician.
Okay. Thank you. Anything else? Real quick, I saw Bill in Los Angeles. You arrived late. Did you need any time tonight?
I actually just wanted to ask a question if anyone's had any experience with this thing they call PAE.
Yeah, we can get to that, but do you need time?
I don't, no.
You don't or do?
No.
But you have a question.
Bill needs time to approach that PAE question.
Yes, exactly. Okay.
So we'll get back to you.
Got it. All right, Gary, you can move on.
Okay, well, we'll roll back to Hector and quick and see if he Hector, what else did you want to ask us or share?
Yeah, just a quick comment. Getting back to the transrectal versus transperineal biopsy. My first biopsy was transrectal, got infected. I was sent to the hospital, and I knew what incontinence meant for a while. The good news is that it didn't last forever. So getting treated without enough reason may have some deplorable consequences because of morbidity. So having said that, let me get back to what I found in my research, because I was kind of concerned that my PSA was not doubling anymore. Doubling time was definitely close to infinity. And the other thing that I found that, I mean, that's going to be substantiation for down the road is that if you're taking the COVID vaccines, that provides some sort of marker that the immunologically your defense system is going to be able to target your cancer cells more easily. So that's to be substantiated. But to conclude, what I also found is that finally the NCCN is apparently updating their recommendations to take into consideration genomics, in particular the decipher that was not considered before, and B, the results of the Protect T research that was conducted in England that came with the conclusion that in terms of probability of survival, active surveillance, radiation, and radical prostatectomy didn't have any difference statistically significant. So it took a while, but apparently the NCCN, after many complaints about conflicts of interest, is updating their recommendations.
That's good.
Well,
that's good to know.
To elaborate more on this.
Hector, did you have any questions for us on your case?
Well, what do you make of it? Because as per PSA levels standalone, I could be in this group, I could be in the intermediate group, and I could be in the advanced group, depending on whether we consider the finasteride or not.
Again,
common case.
Of all the webinars I've been to, you can't put all your eggs in one basket, especially with the PSA test. It's not the best. It's not the best indicator. Unfortunately, it's the gold standard, like Dr. Dan says. That's what. There's so many. I mean, that's the one that sends you to the urologist. I mean, that, you know, there you go. You go to your doctor. He says, "Oh, your PSA is 4.2. Go see the other guy." So it is definitely the gold standard. But you can see by all the ISO PSA, PHI, all the new tests out there, it is not foolproof. So you're saying, well, I could be in this group, that group, or the other group. Hopefully you can stay in this group. It would certainly be your continued diligence with the disease and the journey that you're on. I don't think anybody's got the answer. You know, what group should you be in? And you mentioned something about the COVID vaccine. Is that your opinion? Has that been substantiated? Is that a theory? I was a little lost when you were explaining about the COVID vaccination, Hector.
Yeah, and let me give you an answer for that. What I did is I went to AI and start trying to explore databases and find consolidation of medical research about why my PSA was not anymore growing. And one of the comments I got back, and you know AI is not perfect, but is that there is some recent immunological findings that by taking the COVID vaccines, some types of cancers have been improving because of the detection and easiness for your defense system to target and destroy those cells. There is a special in NPR from a couple of weeks ago about those findings. So I haven't gone to the point of collecting evidence and medical papers so far. It's pretty new, but that's where I am right now. There is some backup for those comments.
Okay, well, what you call it? It certainly keep. I'm interested. Certainly keep us posted as to as your progress as you go along. And as I said, and I've mentioned it before to the group, we have all these things: Decipher, Polaris. The list goes on, and luckily, it keeps growing because there's always something new around the corner. And the longest you can stay on this part of the journey, hopefully forever. But the longer you can stay out here, something might come around the corner that might really be of help to you. So that's what we'll look for.
Yeah.
Is there anything else we can help you with, Hector?
If you leave me your email or a particular email, I could forward the link for the NPR special with a comments about these findings for the immunological effects.
Yeah, I'll put it in the chat.
Okay, sounds good.
Okay.
Hector, when was your last MRI?
It's been probably half a year ago.
And how did it look? Or what was the report?
The situation is I have a bifocal lesion before. Last MRI came with two more small ones, less than 1 millimeter. So the concern was, well, the lesions are multiplying, but the decipher is revealing low risk. So I spoke with the specialist at that time, the urologist that did the biopsy, and he said, listen, Hector, this is the situation. Not everybody has the same time cancer. Some cancers grow, some others don't. Some cancers are gonna kill you, some others are not gonna kill you. This one is not gonna kill you. So
So what is the next?
Excuse me?
What is the next recommendation based on that MRI?
You continue following the active surveillance protocol. Your PSA is every 3 months or so, and your biopsies every couple of years, based on need. But the next step, I'm gonna go to the Tampa General Hospital with Florida Southwestern University to see to Dr. Patel, who's a neurologist that is open to active surveillance, show him my findings, and we can take it from there. I went to Tampa General Hospital to see their specialist in radiation, and he was very aggressive trying to treat me, but I didn't give in.
That's good.
Good.
I've been exploring also proton therapy, which is more expensive, and supposedly protons have mass, so there's more stopping power, but there is we haven't found yet some conclusive evidence that that treatment is going to be superior to.
Yeah, we're not talking about treatment here, remember. No treatment here, talk. Go ahead, Dan, you had a question? Dan?
Yeah, more of a comment. Hector, it sounds like you're searching for the answer of where you should be, whether you should be in active surveillance or you should be in low intermediate. And nobody here is going to tell you where you should be. That's up to you. And the question I have for you is, where do you find yourself most comfortable? And it seems like you're not really comfortable anywhere, that you're continuing to search for an answer that you're the only one that can provide. Nobody here is going to be able to tell you where you should go. So, I mean, you clearly have done research. You have some really strong opinions, I think, on your own care. And honestly, that's the best that you can do, because you're the one that can only be your own best advocate. Nobody else can do that for you. So go with what gives you the most comfort. And if that's active surveillance, then go in, continue to do your research. there is a point, at least I have found, where you can get so much information that you are paralyzed with a decision to make, and it makes that active surveillance, what Dr. Dan said, is anxious surveillance. So try to use less anxiety and more analysis, and then whatever makes you most comfortable with. I think from everything that we heard, your numbers, you're a clear candidate for active surveillance. But if that makes you uncomfortable, then you have to explore your options. So that's all I have to say.
I agree, but I mean, I find with active surveillance and even further, the many times people get treated unnecessarily by anxiety, either patients or anxiety, or worse, specialist anxiety. So,
yes, you're absolutely
right. No, I haven't found conclusive evidence that I should get treated, so I will continue doing what I'm doing, and I've been told that by several urologists. However, it's not a bad idea to have a plan B, just in case, because we never know enough, and cancer could be something that betrays your expectations. All of a sudden, something unexpected results. So that's what I just keep doing research. But yeah, I don't consider myself in a situation of anxiety right now.
Okay. Well, you come across a little anxious. That's all. That's from my perspective, listening to what you're saying.
Oh, no, more than anxious. I'm up to a point unsatisfied with the dominant paradigm, because I've seen other cases, even with people with a 3+3 that gets treated.
Yep.
And I consider that unfair.
Well, none of us here would advocate for unnecessary treatment, and somebody with 3+3, all of us would consider that unnecessary treatment.
Absolutely, but it has happened more than once, and in particular, the robotic urologists are very willing to do it. So,
and I think we need to move to Dr. Dan. He has a question too.
Yeah, I wanted to follow up and give a fairness and political fairness thing here. And it was not just the COVID vaccine. It was people who got COVID or got the COVID vaccine had very slight elevations in their PSAs, probably what we would call not clinically relevant. So it's not the vaccine, it's COVID. Second of all, in terms of where people are, yes, the PSA is a very imperfect test, but right now the NCCN still uses a PSA of 20 as distinguishing between people who should be on active surveillance and people who should not be on active surveillance. And anyone on finasteride can't use that number reasonably. And the third thing I wanted to ask is, are we going to try and get back to Bill about his question on prostatic artery embolization?
Absolutely.
Yeah.
Absolutely.
Yeah,
We're gonna
we
get
are.
the mix.
But Dan, I just want to say, I think you'll find, because I just looked this up, if you have a PSA higher than 20, you're actually considered to be high risk. I think you'll find it's 10 to 20, between 10 and 20 at the NCC.
Yeah, they want you to be less than 10 to be low risk. They want you to be 10 to 20 to be intermediate risk, and anything over 20 is considered high risk by NCCN.
High risk, but I think what you said, you just said something that if you're over 20, you're not eligible for active surveillance. I would say if you're over 10, you're not eligible for active surveillance. Between 10 and 20, you really need to start looking at something more. Yeah, 10 is the number for the AS guys. 20 is the number for the next group up.
Right. That's fair. Yep.
If you allow me, as far as I understand, and that's as per the latest publication of the NCCN guidelines, now the intermediate risk has been modified to pay attention to the Decipher and to the protected trials. So not necessarily 10 is the cutoff line for separating intermediate unfavorable and favorable risk. So I don't have the document with me right now. I just found the reference, but I think we can go and find the document and see what changes have been introduced. And as I mentioned, that was pretty recent.
Okay. Yeah, we'll have to take a look at that. Anything else? Anybody else have anything for Hector? I got a hand up. Ignacio.
Yeah, I have a question on NCCN and the absolute PSA. Be it 10 or 20 or whatever. I'm a little bit concerned about that because it doesn't take the size of your prostate into account. So like me, for example, I have a.
You're right.
Go ahead.
You're absolutely right, but it's one of a number of factors.
I see.
So, they will say if you're this, if you're that, or you're the other, if you have one of these things, if you have two of these things, if you have three of these things. I will put the early, there is a patient version of the early prostate cancer diagnosis. And I have a link to it, I think, and I'll put it in the chat window. I know that I downloaded it and I have it on my computer, so I have a PDF of it.
I have the link, I think.
You can read the guidelines, and they also publish patient-centric versions, which are pretty good, but they're not great. A couple of years ago, I went through them in detail, and I think I found something like 60 or 70, and they adopted 40 of the changes I gave them. So, and then we tried to do it again last year or 2 years ago with a bunch of us, but we never completed it. It's a big job. It's a big job to go through these guidelines and correct them.
What I would be interested in is I believe the guidelines attempt to catch the largest percentage of people possible, right? But is that, like, let's say, is it 60%, 70%, 80%? In other words, the number of outliers has to be pretty significant.
Yeah. Oh yeah. But one size doesn't fit all, and we know that.
Right, exactly. So, right,
we
exactly.
know that.
So that's what I'm saying is that how many of the all, does it encapsulate?
So the thing to do is to say to somebody like Peter Carroll next time you talk to him, Dr. Carroll, can you have a word with some of your buddies and let's try and get density in as a factor in these NCCN guidelines?
Oh, 100%. And that's precisely my point. I don't want to talk about me because I didn't ask for time, but according to NCCN, I am clearly unfavorable intermediate. According to Peter Carroll, who I blindly trust, I'm suitable for active surveillance.
Based on your other factors, yeah.
And that's why, as to Dan's point, being your best advocate, because you've done the work, you've done the research, you've talked to the professionals, you've gone to PCRI, you've done everything you can possibly do to take you out of just a blanket statistic and to put 100%. You into another group, which is perfect. And like Rick 100%. Said, one size doesn't fit all, but they have to print something. So that's what they print. They're going by
guys.
pools of data.
I'm going to put. I just found the early stage guidelines. I'm just putting a link to them in the chat room. Now remember, this is not just for AS. These are early stage guidelines for prostate cancer. These include the guidelines for if you're a low intermediate, or if you're high risk, or if you're metastatic. This is not early low risk active surveillance specific. Okay.
Rick, was this what was published in the AUA journal?
No, this is I don't know, but these are the NCCN guidelines. These are not the AUA guidelines.
So I can't. AUA,
yeah. Is it the same
you
one
had your hand up
in April of 25?
Yes, I believe so. Yeah. There's a guy with a. There's a Hispanic guy or African American. I think he's Hispanic with a hard
Yeah.
hat on.
Yeah, I just put it in the chat earlier, so we may double up on the links.
Okay. Good job. Well done, Eric.
Dan, you had your hand up?
Oh, Dan.
Yeah, I just wanted to mention it, sort of on the same vein of what everybody's been saying about one size fits all. I sent Rick a couple of weeks ago a very interesting and I thought thorough review of AS criteria from a guy that I didn't really know before on YouTube. And then I sent it to Gary, to you and Hugh last week. But, you know, he said in that thing, and maybe this will make Ignacio feel a little better, that the rising PSA should never be a reason that this by itself to discontinue a man from AS. So this is an area in the field of that you know I think is open for some debate. So
just to follow up on that, and with a big shout out to Dan and also to Eric, and I think we asked Dr. Dan as well. I can't remember, but we have asked them to review these type of materials, and if it's important, somebody will write them up, one of them, or we'll have Kiernan write it up with some instruction. We'll put it on the blog so you can find it again. We'll include it in the reminders, and we'll probably put it in some of the other reminders. So, for example, the reminder that you had in yours this week about Decipher that Boykin wrote, Colonel Boykin, he actually wrote that for low intermediate. So we want to share this information around, and I don't want it all to come to me because I just don't have the time. Not only don't I have the time, I don't even have the knowledge that some of you have around AS, because it's not really a field that I don't follow AS that closely, and I don't follow the new articles. But if you've got something, get it to the moderators, we'll review it, and if it's good for everybody, we'll get it out there. That's what we want to do.
I have that video, Dr. Dan, and I started the review, ran it through Eric, and I haven't been able to push it to Kieran. I've been consumed with a bunch of other things, but yes, I agree. That's a pretty good review and summary of active surveillance. It can get overwhelming, but if you go through it a couple of times, I think it's a really good summary of the things that the questions that people would have getting into active surveillance. So I should have that out by the end of the week to Kieran.
Excellent. Okay. All righty. Is Mitch back? All right. And then we'll certainly get to Bill Harrison, PAE, which Mitch might have a comment about PAE, correct?
Possibly, yeah, sure.
Okay. All right, Mitch, go ahead.
Okay, thank you very much. It's very informative. I really appreciate all that I'm learning from you guys. So I had I've had several MRIs. I have two PIRADS lesions, PIRAD 3, and my PSA went up to 9.4. And then I did an ISO PSA, trying to sort out what the source of that elevated PSA might be, whether it was sinister or not. And that gave me a reading well over the normal. Normal cutoff is 6, and I was at the range of 10.2. So my urologist said, well, let's go ahead and get another MRI and see what it shows. And subsequent to that, she went ahead and scheduled a biopsy. I guess what triggered that was the ISO PSA. Well, I sort of jumped in and contacted an AI company, Bot Image, and made arrangements to upload my MRI data to them for an AI interpretation, which I did. And I was surprised at the results. It said there were no suspicious lesions, no PIRADS, no Gleason 6, no suspicious lesions. When I went back and subsequently contacted them, they said, well, we don't program the algorithm to detect anything but clinically significant cancer. So everything that you mentioned, PIRADS 3, Gleason 6, we don't even look at it. We're looking for the bad stuff, and you don't have any bad stuff. So I'm left with this sort of dilemma. I have ISO PSA saying you have bad stuff, and I have AI saying you don't have any bad stuff. So let's get a biopsy and see what we find out. So I got a targeted biopsy, transrectal, because we don't have transperineal in my area. 2 days ago, I'm fine, no signs of infection. Got the pathology report today, and basically status quo, Gleason 6, 3+3, no signs of any aggressive cancer. So the AI won that battle, and the ISO PSA lost that battle. Several interpretations on that that come to mind. One is that the ISO PSA is it's new, and perhaps that was a false positive. Perhaps there is something of a sinister nature lurking in there, but maybe it's microscopic in size and wasn't detected on either the MRI or the biopsy, so we'll keep an eye on things. But to me, it's a sign to hold the course and stay on active surveillance and stay away from any treatment. So I wonder what you guys think.
Nice. Good to hear.
Congratulations.
Oh, now we
Yeah, very
yell
good.
at somebody again.
Concur with your assessment.
Yeah, are you going to get a second opinion on your pathology report?
Yes,
Your
thank
bio-
you. I've already hand taken the order down to the lab. I didn't run it through my urologist's office because I don't want to get it lost in the faxing. I hand carried it down there today, and they're submitting it to Dr. Epstein.
Excellent.
The other thing I was going to ask about was I think maybe I should go ahead and run a decipher on it as well. What do you think?
Have you ever had it done before, the decipher?
I've had it done a couple years ago after a biopsy, and it was a low score. I don't remember what the number was. I'm figuring that this may be different tissue now, so maybe I would do it on the current tissue.
I would think that's up to you and your doctor.
If it helps, I've been told to go ahead and get another one. So and it's been about maybe 2 or 3 years.
Yeah, I think the time interval plus the tissue can change, and then the sampling can also be a little different, potentially.
Out of curiosity, was the radiologist report different than the bot image report?
Well, here's the thing. The bot image people said, we program our algorithm to look for clinically significant cancer. We don't care what radiologists say. We're not trying to correlate it with that. We don't report PIRADs. We don't conflict with anything they say. We just tell you we do or do not find evidence of clinically suspicious cancer.
So what was the radiologist report?
Radiologist report was two
PIRAD?
PIRAD 3 lesions. There was a new one from the last MRI a year ago. But both of those PIRAD lesions in the past have biopsied as negative. So maybe they're fibrosis or something else. They haven't been where they found the Gleason. They found the Gleason 6 in the systemic part looking elsewhere.
Huh, interesting. And it was 1 core or 2 cores or?
In the current, I had actually 6 cores with Gleason 6 in it, ranging from 5% to 10%. And there was 1 core at 30% and 1 core at 40%, but they were Gleason 3+3. So I'm wondering if that's significant. Is the volume issue something to consider?
Yeah, you're right on the edge. I mean, I had 11 cores of 3+3, so I'm high volume. So I'm wondering if 6 or more is considered high volume or not. Jeff, do you know anything? Is Jeff still here? I guess he's gone. Yeah, I don't know. You have to ask the doctor if 6 or more is considered high volume.
But also the question would be, if you had 6, did you have multiple cores from one area that reveal that? Because that only counts as 1 if you did. And how many were your total sticks did you have? What was your percentage?
Total sticks were 12 on the systemic part and 3 from each region of interest. There were 2 of those, so that's a total of 18.
Wow.
Well, 3 would be obviously targeted, so we know those are going to have cancers. There's the other 3 that are systemic, that are just some random cores taken out. It's only half really, you would say half. Really, only 3 cores had cancer beyond the targeted, in my mind. I could be wrong.
You can also look at it, or at least I looked at it that way, in the number of regions where they got a result. If that makes sense.
No, these are good thoughts, and I'm jotting them down because I'm going to call Dr. Epstein after I get his reading on it, and those are questions I'll ask him.
Good. Mr. Dan, go for it.
So I don't want to open up a whole nother can of worms and have a big debate, but we talk about these Decipher scores pretty regularly. And my understanding is that Decipher is that none of the organizations currently recommend Deciphers for 3+3 Gleasons. It's usually recommended for intermediate, to decide between favorable and unfavorable intermediate. So I know that some of you may disagree, and I know they're being ordered pretty regularly, but I guess I would ask Mitch to hold off on that and talk to Epstein and then decide, if he came back with a higher score, then it would definitely be indicated. But I don't know that the Decipher score is the right test for him right now.
Thank you, Dan. That's a good point. I'm going to ask Dr. Epstein that as well, because, I mean, with the case of the ISO-PSA, one has to be wary of false positives.
Yeah, there's a lot of research tools out there, and not all of them are ready for prime time. But I mean, the Decipher score is clearly useful. It's just my understanding from reading the recommendations of different organizations, it's not recommended for people who are in all other criteria, low or very low risk.
Does volume play a role, Dan?
I didn't hear that.
Oh, sorry. Does the amount of volume play a role in Decipher? If you have 10 whatever.
I haven't seen any current recommendations that change very low Gleason, great. According to what I read, if you're Gleason 3+3, you're still, level 1 risk. So, I think volume comes a lot more into it when we get into the 7s. But anyway, that'd be good to discuss with. I'm sure Dr. Epstein can give you some advice on that.
Thank you.
Dan, I'm pretty sure that I concur that we had somebody on a webinar, one of the top guys, because that's the only people that luckily enough that we will share time with us. And yeah, for grade group 1, 3+3 Gleason, Decipher was not a viable option. Along with what you just said, it's more for the low to intermediate to make that to make a better decision when you're in that particular group. But I do remember that Decipher, I've never had that type of test yet, because I've always been 3+3 grade group 1. But that, again, something else to explore with Dr. Epstein. And Mitch, didn't you weren't you thinking about that PAE, and you got some advice along the way from one of the other gentlemen?
Actually, I got some advice from Dan on he cited some research. But the issue that Dan brought up was how long the procedure would be durable, as opposed to aquablation. But I did look into PAE, and the pros and cons in my mind are, one of the pros is it's an outpatient procedure. You don't have to go in the hospital overnight. The effects in terms of bleeding afterwards are usually less. Aquablation, I have a question for you guys, especially if you've had it. I was reading that Medicare may or may not cover it, depending on if you have prostate cancer. And one of the cutoff criteria was that you had to have a negative biopsy within the last 6 months. What does a negative biopsy mean in terms of that Medicare criteria? Does that mean, a grade group 1 Gleason 1, 3+3? Is that a negative biopsy, or does that mean that your biopsy showed no sign of aggressive cancer? I'm not sure what that means. So, question
Mitch, it means they don't want to. There are people who have urinary obstruction from cancer, and they don't want to pay for aquablation, which is a treatment for BPH, if your problem is really caused by cancer.
Okay, so if your doctor says it's indicated it's not caused by cancer, then they'll probably pay for it.
That's what I would guess.
Okay. The other thing about PAE is you've got to have a screening test to determine the patency of the arteries that they're going through to your prostate. For example, you have to make sure that you don't have severe sclerosis or atherosclerosis or other impediments along the route. In my case, I got a CT angiogram, and it showed some soft plaques along my abdominal aorta, I think it was. So I raised the question with the urologist who was going to do the procedure, is that an issue? Because online it said, well, they could break those plaques off, and then you've got all kinds of trouble going downstream, and so forth. He said, no, not, it's very mild in your case, and you usually don't worry about it unless it's more severe. And if you are worried about it, they'll go through your wrist rather than through they can go through your femoral artery rather than your wrist and avoid the issue. So that's just something to think about.
Okay. Well, thanks for your insight, because I know that Bill Harris was asking about PAE. So, Bill, you got some questions?
Well, just a quick history so you know where I'm coming from. I'm a BRCA2 positive person who's had breast cancer and pancreatic cancer. I've had BPH now for about 7 years, 8 years, somewhere in that range. My recent PSA tests have gone from in October of 22 from a low of 2 up to 11.5 this past July, and I'm due for another test later this week. And I've been reading up about the procedures because I'm showing, of course, the all the urinary difficulties that BPH presents. I did have a biopsy, but that was many years ago, 8 years ago. It was a 12-needle kind of blind biopsy done rectally and came up negative. So with the urinary difficulties I'm having now and my risks going forward because of my BRCA2 situation, as well as the long-term BPH, the doctor mentioned that there were these procedures, one being the PAE and the other being this aquablation version of PAE, I guess. Both going for the same result, just different tool being used to do it. And I'm reading a lot and I'm just kind of lost.
Well, Bill, there are actually two different procedures. The PAE is prostate artery embolization. So they go in and they cut off the blood supply to the prostate so that it dies, the prostate tissue dies. Aquablation, on the other hand, is like a sort of a pressure washer thing where they go in with a high pressure water tool or whatever, and they destroy the tissue that way. It doesn't involve going through your vasculature.
Okay.
Yeah, two very different procedures. Michael, up on the top of the screen for me, I believe you've had aquablation done, correct, Michael?
Yes, I had it done almost 2 months ago now. Are you, Bill, are you on any anticoagulants or anything with this long medical history you're given? I'm just going to ask that.
No, none.
Okay. I was going to say, PAE sometimes is the route to go if you're on anticoagulants, but they're completely different procedures altogether.
With the same end goal, though.
My reading says more of the people that have PAE done are the ones who are on anticoagulants, have a lot of chronic illness maybe, and they worry about how well they can tolerate a surgery. And of course, the bleeding from like the aquablation is present if you're on Coumadin or one of the anticoagulants.
So, Bill, a question too. You mentioned, is your status in reference? Have you been diagnosed with prostate cancer?
No.
Oh, okay. I was going to say because both of those procedures will make future imaging of your gland more difficult if you're under, if you have other lesions in there. So just something to consider.
The last MRI that I had was about 6 months ago, and it showed no scarring, no lesions or anything of that nature. But the volume has increased steadily, and it's up somewhere around 65 or 70 at this point. And as I said, the last PSA reading was 11.5.
Of course, some of that has to do with the growth, the growth and size of the, we discussed that, the growth of size of the gland itself. And of course, two issues I think that were brought up is the PAE procedure, which is vascular, has the shortest duration of success, supposedly. I think that was a take on it, where if you get the aquablation, has longer lasting results, because it sounds like it's certainly more involved than the PAE. Dan, you've got a question?
Yeah, Bill, I'm a BRCA1 carrier, so I empathize. We walk through the doctor's door and all they see is cancer when we walk in the office. And you've had a bunch, but with a BRCA2 carrier and an 11.5 PSA, you have got to rule out prostate cancer before you start worrying about your BPH, because your prostate density, your PSA divided by your prostate volume, even the generous volume of 70, because you could be 65, is over 0.15, and that's sort of the cutoff for when they want to really think about whether this could be prostate cancer. If you do, as Mitch suggested, if you do prostatic artery embolization, your PSA is going to go down. You're going to lose the ability to follow that. You're going to think everything's fine. And if there's cancer in there, it's not going to be fine. So I know you're sick of hearing about cancers. You've had some bad ones. But I think you got to play the hand you're dealt. You got to play it straight, because if you just came to us and gave us these numbers, I would say, you got to rule out prostate cancer first, and then worry about treating your BPH.
Right.
How often are you getting MRIs just to keep track of things?
I do that regularly.
Every year or 6 months or?
I do MRIs. Now I'm at once a year. Up until this past year, it was twice a year, following up on the two cancers as well. And a ultrasound is scheduled also coming up.
I wish I had better news for you.
Any biopsies needed in the future, or they're just tracking everything with MRI?
Right now, tracking. I'm in the midst of switching physicians, because I went from January 1st, changed my coverage. And so I've got to enlist a new urologist on this program, because my old one is not covered by the new thing. I'm not concerned about choosing one. I'm in the UCLA Advantage program, and they've got some pretty fine urologists in my area here in Los Angeles.
Yeah,
that's good.
It sounds like you're doing the right thing. Let's get to Rick, and then I think we'll wrap things up here shortly.
Thanks for the time, guys.
Bill, do you know Mark Scholes in LA, the prostate oncology doctor?
No.
You might want to just want to.
No, I would not recommend shows in this situation at all. If it were me, this is why I had my hand up. I think what you really need is somebody in the GU, in the urologic oncology team at UCLA, who's really familiar with BRCA. Now, up north, we send people to Dr. Carroll, because he's great in following the guys who carry BRCA. It's not simple. It's not just somebody who's a good urologist. And the issue that Dan points out is very, very pertinent. So, or very pertinent, because maybe I should have said and not pertinent. it's really important that you get a really good, not just any old or somebody who's convenient for you because they're at the west end of the valley or something like that. You got to have a really good urologist. I don't know if Egner has got his license yet, but somebody like Egner would be a really good person. He's the new chief of urologic oncology at UCLA, and he should have his license by now, and he should be taking patients, and we can help you get in to see him. If not, there are a couple of really other good ones, but you want the guys who are really big on following BRCA. Do you have a quarterback oncologist at UCLA, Bill?
Yes.
I would ask them, I would consult with them and ask them who do they consider to be most up on HRR mutations and following men with HRR mutations, and in particular BRCA mutations.
I actually have an appointment with him tomorrow.
Okay, great. Just tell him you need a new urologist and you want somebody who's really up on this. I mean, Peter Carroll has been phenomenal for us with some of our BRCA guys. I don't know if there's anybody in here right now, but he has been so good, and he takes a particular interest in BRCA men. So that would be my advice.
Okay, thank you.
Okay, gentlemen, anybody got anything? We're running a little late. Anybody got anything else to wrap up?
Yeah, if you need to download any of the
you
chat,
need to download from the chat. Yep, do that now.
Yep.
And
three vertical dots. You can download the
Did
chat.
BJ go or?
No, I'm here.
Yeah, did we get to you?
Yes.
Okay.
Thank you.
Alrighty, moderators can hang out for a minute. All right, gentlemen. Till next
Thanks,
week.
everybody.
Everybody take care. Have a good evening.
Good night.
Thanks, everybody. Good night.